Hello, everyone. What we're going to talk about today in the first talk of the session is how intracavity ultrasound can be used for ultrasound-guided intervention. I think we can all agree that ultrasound is an established modality for intervention, and the introduction of ultrasound contrast agents further improve the imaging quality of ultrasound for guiding intervention. So ultrasound is used for and an important modality for intervention. And broadly speaking, ultrasound contrast agent can be used in two different ways, either intravascularly or be injected into a body cavity and used in the intracavity use. And these techniques can either be used in isolation or synchronously to help with our intervention. And the aim of my short talk today is to explore the potentials of intracavity ultrasound as an adjunct for interventional procedures, in particular giving examples which illustrate the spectrum of clinical applications of intracavity contrast ultrasound, which could be applied in interventional procedures. The first thing I'm going to say is that, as in any contrast ultrasound examination, intracavity ultrasound should be performed after an unenhanced conventional ultrasound examination is fully evaluated. This will allow the operator to identify the area of interest and establish the suitability and plan a subsequent contrast ultrasound examination. After that, contrast ultrasound agent can be instilled into any physiological or pathological body cavities in the GI, GU, biliary, or in a cavity that's pathological, such as an abscess or collection. It is worth noting that intracavity ultrasound is different from intravenous contrast ultrasound, that the volume of solvent is much smaller than the full blood circulation volume. So a much smaller dose of ultrasound contrast agent is required. It is also important to point out that adequate dilution of the contrast agent is essential to avoid posterior acoustic shadow artifacts secondary to a high concentration of microbubbles. In our experience, for intracavity ultrasound, adequate dilution could be achieved with a dilution of 0.01 mils of Sonoview in approximately 40 to 50 mils or 0.9% of normal saline. The other point that's often overlooked is that the lack of circulation of ultrasound contrast agent in a confined cavity means that the microbubbles remain stable within the collection for up to 20 to 30 minutes. Destruction of the microbubbles by high-energy ultrasound pulse is therefore required before repeating an intracavity contrast ultrasound evaluation. Clinical indications for intracavity contrast ultrasound is being included in EFSOM guidelines on interventional ultrasound. Broadly speaking, clinical indications for intracavity contrast ultrasound include confirmation of drain placement and effective drainage, evaluation of a physiological or non-physiological cavity, and detection of communication between two cavities through a fistula tract. One of the most commonly performed ultrasound-guided procedure is drainage. Intracavity ultrasound through drainage catheter can be performed either immediately after drainage catheter is inserted or in the subsequent follow-up period. Intracavity contrast ultrasound through a drainage catheter primarily facilitates the confirmation of catheter position within the collection. But equally important, intracavity ultrasound can also provide additional assessment of the effectiveness of the drainage, particularly in the collection with multiple parts. Here we can see a case of intracavity contrast ultrasound where the microbubble ultrasound contrast agent is injected through the drainage tube, confirming the adequate placement of the catheter, and also shows the morphology of the abscess cavity. Another example of an intracavity ultrasound in a septated ascites with ultrasound contrast agent injected through the drain, showing localization of the contrast agent within one compartment only, rather than free diffusion in the intra-abdominal space. In a collection with multiple loculations, intracavity ultrasound can confirm the correct placement of the drain within the abscess, and also shows that the drainage can be effective by showing dissemination of the contrast agent into seemingly disconnected aspect of this abscess. In the same way, intracavity contrast ultrasound in the biliary system through drainage catheter enables determination of the adequacy of the drainage catheter position. For instance, here we have a case where a contrast ultrasound cholangiography is performed and confirms the adequate placement and patency of the biliary drain and drainage into the hepatojejunostomy. Moreover, this is a very interesting ultrasound case, and I just want to leave you a few seconds just to look at this case and observe carefully. This case will show the uniqueness of contrast ultrasound in demonstrating unique pathologies that is difficult to be demonstrated in other imaging modality. So having gone through the case, if I tell you that this is an intracavity contrast ultrasound cholangiogram, the keen observers among you may probably want to ask me, isn't it surprising that the liver parenchyma enhances in an intracavity contrast ultrasound examination? And I think you'll be correct. What this case is showing us is that there is an abnormal communication between the biliary system and the vascular system. So when we look back into the case, at 9 seconds of the examination, we can see opacification of the right hepatic arteries through contrast agent injected into the biliary tree. And by 63 seconds of the examination, we can see the whole parenchyma opacifying, indicating that there is communication between the biliary system and the vascular system within the liver. So indeed, this is a case where we can see that contrast ultrasound has the unique ability to show an arterial communication with the percutaneous biliary drainage tube. And this is a complication associated with percutaneous transhepatic biliary drainage. And this is due to the superior temporal and spatial resolution of contrast enhanced ultrasound. In the urinary tract, one of the commonly performed procedure under ultrasound guidance is a percutaneous nephrostomy. This is routinely used in patients requiring urinary drainage or diversion. And a frequent technical difficulty contributing to the failure of a procedure, including the lack of visibility of the target calyx in the cases where non-dilated collecting system exists, or when there are echogenic blood clots or pus or debris within the renal calyces, as in this case shown here. We know that intravenous contrast ultrasound improves the visibility of the calyces by revealing the non-vascularized renal calyceal system against the background, enhancing renal parenchyma. So, intravenous use of contrast ultrasound agents may help us in performing a difficult nephrostomy. Equally important, there are specific techniques for contrast ultrasound assist puncture for nephrostomy, with administration of a small volume or a single drop of diluted ultrasound contrast agent through a puncture needle. So here we have a clip of a live movie clip from a nephrostomy insertion. What we have done is putting a drop of contrast agent into the puncture needle. The first thing that we notice is that this greatly improves the visibility of the micropuncture needle. With contrast ultrasound guidance, the contrast can be used to visually confirm a successful puncture. So in the next movie clip that I'm going to show you, you can see the moment when the collecting system is punctured. There's a high pressure within the dilated collecting system. The urine flows back through the puncture needle and push the microbubble contrast out of the needle. And you can see a visual confirmation of this successful puncture. In other cases, in particular, in the non-dilated system, there may be such a high pressure in the collecting system to push the urine back, but we can still get a positive visual confirmation of a successful puncture. What we can see is that upon puncturing the collecting system, microbubbles are visualized within the collecting system, instantly confirming that we are in the correct position. And when we compare this technique to conventional fluoroscopy guidance, contrast ultrasound guidance offers a further technical advantage that if the initial placement is inaccurate, microbubbles can be destroyed and therefore would not leave distracting blobs of contrast material that interferes with the procedure, as in the case of procedures performed with iodinated contrast material under fluoroscopy. After a successful nephrostomy, ultrasound contrast agent can then be injected through the drainage catheter to confirm the drainage catheter position or placement. This either can be performed immediately after procedure or more often in the follow-up period. So on the top row of the image, what we can see is that the nephrostomy tube is dislodged. Therefore, when we inject contrast agent through the tube, there's pooling of the microbubble contrast in the perinephric space. In the bottom row, we replaced the nephrostomy tube and again injecting the contrast agent. This time we can see the confirmation of adequate nephrostomy placement with visualization of the microbubble contrast in the renal collecting system and the proximal ureter. More importantly, we can get more information from this study. So an unobstructed drainage into the bladder can be confirmed with a contrast nephrostogram with visualization not only in the collecting system and ureter, but also with microbubble contrast jets into the bladder. Occasionally, we can observe the morphological changes within the ureter. Here we can see the reason for the obstructive uropathy is due to a distal ureteric stricture, indicated by the blue arrow here. So from our experience, contrast nephrostogram therefore has the potential to become a feasible alternative to conventional fluoroscopic nephrostogram. And this is particularly useful for patients who are critically ill, as the examination can therefore be performed at bedside on the intensive care unit. Before I reach the end of my talk, I also want to show you an interesting case here that I want to highlight the point that intracavity ultrasound may be valuable when the clinical scenarios requires an answer to the question whether there's any communication between collection and adjacent structures. So this again is an example taken from the urinary tract. This patient had multiple radiotherapy into the pelvic region, and there has been ureteric injury. We have performed the nephrostomy and injected contrast, initially through the nephrostomy tube. On the movie clips here, what you can see is the contrast agent in the proximal ureter, but subsequently leaks out more distally in the pelvis, where it forms a collection within the pelvis, and we can see the accumulation of microbubble contrast agent freely in the pelvis. But what's surprising subsequently is that as we watch these contrast flow in real time, what we can see is the microbubble contrast agent flowing into the small bowel loops within the pelvis. And the excellent temporal and spatial resolution of contrast ultrasound allows us to make real-time demonstration of a communication between an intra-abdominal collection and the small bowel loops. And in this case, we have demonstrated in real time that this patient has the diagnosis of urethroenteric fistula. And this is only demonstrated through real-time visualization with even a small quantity of microbubble movement through one compartment to the other to confirm the diagnosis. And we have tried alternative diagnosis, alternative imaging modalities, but it's very difficult to demonstrate it in real time. So on the CT examination, what we can see is contrast within the small bowel loops on a urographic phase image CT. But the real-time movement of contrast cannot be demonstrated as clearly as what we saw in the ultrasound examination. There are a few other applications that we can use within the abdomen. So in radiologically inserted gastrostomy tubes, with the same principle, we can demonstrate whether there's any complications or leaks. Or in this case, we can see an hypoechoic collection adjacent to the tube, but on contrast study, we cannot see any continuous leak to show that this, in fact, is a collection, but we have managed to exclude the presence of a continuing leak. And the placement of the gastrostomy tube can be confirmed with contrast within the stomach, which is recognizable due to the presence of gastric rugae. My colleague, Dr. Sellers, has prepared an excellent presentation on pediatric lungs following this talk. So with that in mind, I'm not going to spend too much time on the pleural space, but the only thing I would say is that all the principles that we have observed within the abdomen can be readily transferred to the thorax, and administration of ultrasound contrast agent into the pleural cavity through the drainage tube is useful to delineate the collection, confirming the drain position, and it may alter the management for the patient. Finally, I just want to say that to sum up, the current state of knowledge suggests intracavity ultrasound may add value regarding needle catheter position, cavity morphology, and presence of fistula in a collection. And it's currently recommended that intracavity contrast ultrasound should be considered if alternative imaging modality carries a higher risk for the patient. For example, the need for transfer critically ill patients. But in practice, our experience suggests that intracavity contrast ultrasound has the potential to address specific questions and often offer tailor-made solutions for complex clinical and logistical challenges that we see every day. Thank you very much.
Dr. Huang. And I wanted to a bit remind to all the participants that this is not only one-way communication. You have a chance to ask the questions to the speakers. Those questions that will not rise now, you still have the whole webinar time to ask them, and we will try to address them as much as we can. But we have already one question, and the first of them is, what technical maybe settings are different from typical intravascular use of contrast? Maybe there are some different mechanical indexes that you select because you use less contrast media, or what are the adjustments of the system? And also, does this contrast involves any legal or compliance issues? Meaning, are there any restrictions of this use, or kind of maybe contraindications of this exact use that might cause unnecessary harm or unnecessary problems, either for imaging, either for patients?
Thank you for the questions. To address the first question, what I'm going to say is that the principle of contrast ultrasound, either intravascular or intracavity, would be similar. I think the important factors to consider would be that the target area that we're imaging has to be well demonstrated on the conventional ultrasound examination, and that is why we usually suggest to evaluate your conventional ultrasound images before you plan your subsequent contrast ultrasound procedures. Certain adjustment that may have to be made is that the target area that we're imaging may be more superficial, so that we may have to consider the destruction of the microbubbles. But having said that, it's important to remember that the cavity usually that we're imaging will be in a confined space. Therefore, there is not going to be much circulation washing the contrast out. Therefore, adequate dilution of the contrast would be the most important thing, because if there's too much microbubbles, it's going to cause significant artifact to the image quality. But having said that, it's not too much of a problem. If we have injected too much microbubbles, we can destroy them and repeat the examination safely. In terms of the safety aspect of the intracavity application, most of the most of the intracavity ultrasound used have been trialed in various clinical trials in different body parts. Certainly, there is no increased risk compared to intravenous use of ultrasound contrast agent, and the only documented symptom or complaint from the patient is occasional pain experienced by the patient due to the expansion of a confined cavity. However, our recommendation would be that any precaution that you take when administrating intravenous contrast ultrasound agent should be also applied when practicing intracavity contrast ultrasound examinations.
There is a very sophisticated question from the audience once more about the technical moment. Do we really need the traditional commercial agents, or we could use maybe more simplified shaken saline and some other connected syringes techniques? What do you think is the benefit of use of these specific agents?
I think that is a very good question and a very practical question. And indeed, a lot of the applications that we have used here are not novel in the sense that we have performed these procedures with shaken saline. And what we found is that with ultrasound contrast agent, it provides a much more stable contrast media, allow us to perform the examination in a more controlled fashion. So again, it depends on the procedure planning and depends on what you're trying to achieve. I would say that certainly in terms of image quality and the stability of the contrast media, the commercially available contrast agent does provide more advantage in terms of our imaging performance.
And there was one more question about, is there a place of these intracavitary contrast use in those critically ill patients when we do the palliative cholecystostomy in evaluation of those cystic duct obstructions? Would you use it for this or only for guidance of your procedure?
I think the first thing I would suggest is that if the patient is critically ill, the balance against transferring the patient for a diagnostic examination usually favors performance of a portable contrast enhanced ultrasound examination, which can be performed by the bedside. And the principle of the diagnostic value of the examination will be very similar in what we see, and namely that the key component will be to confirm any drainage catheter or satisfactory drainage position. And I think these key principles are the same in terms of intracavity procedures that we perform for most of the modalities.
Okay, thank you. And also there is an interesting question. Have you tried these contrast media in the joints? Do you have any experience in maybe assessing better application of some blockades or some injections to the joints and maybe better delineate some cavities?
I think that is a great question and it's a great idea, and I'm really grateful the audience share that idea with me. I don't have a personal experience in that, but I would certainly be keen to explore that with one of my musculoskeletal radiology colleagues. Yeah.
Okay. And there was one more question about, in the case of these biliary drainages, you also may see it in your screen, maybe down there. So drainage with liver parenchyma opacification, what kind of concentration you would use? Would you expect liver opacification with the usual low concentrations? I believe no, but...
No. So the case that we've shown, it was very surprising for us to see the liver opacification. So when we planned and performed the examination, it was performed with a very low concentration of contrast, probably a bit more than what we normally do, or 0.1 mils. But I think from memory, I think it was still a very low concentration of contrast. Yeah.
Thank you. And one last question in this part is how long does this contrast stay there? Meaning, if you use it, would you go for intermittent injection in a larger maybe cavities again and again? And how long is that first injection efficacy? How long it stays there and help us to see things?
Yeah, so that's actually a very important question. That contrast can stay for a long time if we are not scanning continuously. So the contrast could stay in a cavity that's confined for up to 20 to 30 minutes. Therefore, one of the examples would be that if we are testing for the patency of the urinary drainage, once we tested one nephrostomy, we need to make sure that all the bubbles in the bladder is destroyed with a high energy ultrasound pulse before we test the other side. So they could last for 20 to 30 minutes within a confined cavity.
Right, it's enough time for any interventional procedure, so no need for extra too much of the contrast, which is useful in some cases.
Yes, yes.
Would you use it for other fistulas, also to vesicovaginal, to maybe enteric, not only what you showed, but maybe for the other fistulas? Would you go for this?
I think the possibility is almost endless, and I think that the examples that I've shown is just to demonstrate the principles how this can be used. And I think the strength and the power of this technique is that it can be adapted to address any specific clinical questions. I think all the things that you mentioned potentially could be tried and demonstrated through intracavitary contrast ultrasound. So the possibility is endless. Yeah.
The sky is the limit, right? For contrast ultrasound for intracavity use. Yeah. I thank you so much. We have to finalize this topic, and I thank Dr. Huang for challenge of the questions, and I thank the audience for active participation. And I want to remind you that at the end, we also will have a quiz. And you will have a chance to test how much did you gain the new knowledge today, and to find some new credit points of your knowledge.